Hey, so let's spend 3 minutes and briefly talk about a clinical crepe for lactic acidosis. Sometimes we might, if we're trying to be bougie, refer to this as hyperlactatemia. Great. So the teaching point I want to focus on here is going to be on the differential diagnosis of hyperlactatemia. It's easy to divide this up into what I like to think of as 3 core buckets so that you can quickly Marie Kondo the different options when you're generating the differential. Type A, type B, and then a sort of subset within type B, which I like to think of as T. All right, so let's break that down. Type A lactic acidosis is just going to be tissue hypoxia. What that means is that the hit makers of hyperlactatemia are essentially going to be things that you're already familiar with. So etiologies of overt shock, hypovolemic, cardiogenic. This is not a teaching video about the complete and comprehensive differential diagnosis for shock, but certainly overt shock will lead to global hypoperfusion and subsequently lead to tissue hypoxia. Now, there are 2 other options when we're thinking about tissue hypoxia that would meet the requirement and satisfy this type A lactic acidosis. Those would be focal tissue hyperperfusion. And examples that come to mind for me are, for example, dead or dying gut, like mesenteric ischemia, or dead or dying limb, for example, like an acute vasculopathy of a limb, or another example might be compartment syndrome. And the last example of tissue hypoxia is going to be if there is a sudden increased demand in oxygen at a particular or global tissue. The perfect clinical example of this, and the most common one that you're going to encounter, is in the postictal or immediate post-seizure state. If a patient has had a global tonic-clonic seizure and they've been rigoring their entire body, it's not uncommon to see impressively high lactate levels in the immediate aftermath of an event such as that. So that's type A lactic acidosis. Let's move on to type B lactic acidosis. Without getting into the nitty-gritty or granular mechanisms of type B lactic acidosis, essentially what it is a dump bucket for everything that's not tissue hypoxia. Now, mechanistically, what that means is that you have to start considering the other biochemical pathways that could lead to shunting towards the generation of excess lactate. I'd rather jump off a cliff than do that with you right now. So instead of us focusing on those nitty-gritty biochemical pathways, I'm just going to give you a couple of common clinical examples of type B lactic acidosis. So one example is going to be, and you can see me cheating and referencing my notes, in oncologic processes. So more classically, liquid onc, but you can also see it with heavy tumor burden and solid onc. There is a biochemical effect that's been labeled, which is called the Warburg effect. And it's sometimes something that we will see in patients who are hospitalized with bad cancer burden. 2 other examples of type B lactic acidosis are going to be liver disease. So in patients who have chronic liver disease or cirrhotics, they're not going to clear lactate as effectively as someone who doesn't have liver disease, and that can certainly contribute to a hyperlactatemia. And last but not least, thiamine deficiency. So I conceptualize this as our patients who have alcohol use disorder, or perhaps our patients who are malnourished for some other etiology. So those are examples of type B lactic acidosis. Now, a subset of type B lactic acidosis are toxins. I think that any good differential diagnosis for the top 30 that you're going to start to develop schemas for over the course of your intern year is always going to include toxins as part of that differential diagnosis. Now, I like to think of toxins not as just basically illicit substances or for example, chemicals that someone who inadvertently drinks or inadvertently is exposed to. But I like a broader umbrella definition of toxins. For me, a toxin is anything exogenous that is introduced into the body, intentional or otherwise. And so what that means is, for my definition of toxins, I'm also including iatrogenic prescriptions, okay? So any prescription that we give to the patient, that I consider to be a toxin, because again, for me, it's an exogenous product that's being introduced into the body. So 3 common toxins that can lead to hyperlactatemia are going to be propofol. You might see this on patients who have had heavy sedation and been intubated and sedated for many days in the intensive care unit. Beta-2 agonists, so specifically albuterol. Patients who come in with a severe acute asthma exacerbation and are put on continuous nebulizers can often mount a reasonable lactic acidosis. And last but not least, nucleoside reverse transcriptase inhibitors, okay? So patients who are on antiretroviral therapy for HIV, a rare but not uncommon thing for us to see in the hospital would be mild or perhaps moderate lactic acidosis from that. So let's recap. I like to think of our hyperlactatemia DDX in terms of 3 buckets. One is going to be type A lactic acidosis, which is tissue hypoxia. That's the classic. That's doing the heavy lifting, the hit makers of hyperlactatemia, if you will. And then type B lactic acidosis, which includes a subset that I like to think of as toxins. That's it.